Yeah, so welcome to Decoding CTO, case 21. I'm Dr. Sharath, interventional cardiologist, Medicover Hospitals. Today I'm bringing a case of balloon uncrossable LED CTO. So my patient is a 67-year-old gentleman, came with unstable angina with an ejection fraction of 62%. His angiogram revealed total occlusion of RCA and LED. He is diabetic as well as hypertensive. This is angiography. You can see LED is completely occluded, and it appeared there is a microchannel, so which will clear it subsequently. So this LED and RCA is also filling retrogradely from septals as well as an epicardial collaterals. Yeah, this is again epicaudal view, which clearly says the total occlusion, and there is a lot of calcium sitting in ostal LED as well as mid LED. And this is a right coronary artery which is totally occluded and also filling retrogradely from septals and epicardial collaterals. So this is a syntax score of patient 38, and Euro score was less than 2. Though he is low surgical risk, in our heart team discussion, surgeon turned down as the graftability of LED was questionable for this patient. So that's when we decided to go ahead with the PCI, maybe 1 or 2 stage procedure based on the duration and contrast usage during the course of procedure. So this is a PCI. So we did an angiogram before PCI. We have not took dual injection as his right coronary is also totally occluded, and we have a good ipsilateral collaterals for this LED. So it appeared there is a connection or microchannel in the CTO, but when we took microcatheter injections, it was clear there is no microchannel. What appeared as a microchannel is actually the diagonal, so which is becoming a link between distal LED and proximal LED. So this is what happens. Many times microchannels may not be present, but it appears in a non-selective injection. So this is an anatomicogram of the patient. You can see this is a total occlusion, and there is a diagonal which is coming almost parallel, appearing like a microchannel to the distal LED, and there is a lot of calcium here, and the length of lesion is also long. We can say a JCTO score of 3 for this patient, and he had multiple collaterals from epicardial as well as septal. Yeah. So yeah, here as the cap is ambiguous due to the origin of diagonal, so with microcatheter injection we can differentiate the location of proximal cap. We can note down here, see there is a trump track calcium which is visible below the diagonal. You can see as marked here. So that basically says that's a vessel, that's a proximal cap too. And IVUS is not useful as the side branch is too small. So this trump track calcium helps us in visualizing proximal cap and also wiring proximal cap. So yeah, we did antegrade wire escalation. You can see this is a Gaia 2 wire, but you can notice Gaia 2 wire is in diagonal here. You can see the curve which it has taken, but actual vessel is here. So this is where it has to enter, but this wire is getting slipped into the diagonal, probably because of the tough proximal cap. So that's the reason we escalated wire to next level, that is Harnett. So this is Harnett 14 wire. So you can see the Harnett 14 entered into the calcium. You can see there is a calcium here and here. So we entered into the calcium. So now the wire is into the proximal cap and into the CTO, and we confirmed it in 2 orthogonal views. You can see here. So once the Harnett is entered, and it's not advisable to continue with Harnett for rest of the CTO crossing, because Harnett wire cannot take loops, or it won't respect any bend in the vessel. So that's why always de-escalate. Once we create a path, de-escalate wire to Gaia and then advance further. That's what we did. We de-escalated back to Gaia. You can see this is a Gaia wire, how it is moving with the bends, and in fact it also reached distal toe lumen, as you observe in this injection. So once wire crossed, we tried crossing with 1 mm balloon, but it didn't cross, and I tried advancing a corsair, it didn't cross, and we used an anchor balloon into the septal artery to cross with the 1 mm balloon, but even that didn't work, so we could hardly cross into the middle of the CTO. So and then I tried doing a GRENADOPLASTY with 1 mm balloon. You can see here. So we dilated 1 mm balloon up to almost 18 to 20 atmospheres. You can see the contrast extravasation here. Despite GRENADOPLASTY, we couldn't able to advance the next balloon. Yeah, so we decided to go ahead with the rota wire exchange and rotablation. So this is what we did. Corsair is in the mid CTO, and then I pulled the Gaia wire and then exchanged to rota wire. So with the difficulty, we could cross. But there is one technique which we can use, which I demonstrate in a graphic. So what we can do is, see, this is how the Gaia wire is across the CTO, and this is a CTO, and we could cross with balloon up to the middle of the CTO, where we could create a space, and then we advanced microcatheter, that is corsair, into the mid CTO. And now we have to exchange to rota wire. So what we can do is, we can, while coming back with Gaia wire, so you spin Gaia wire, you can spin Gaia wire rapidly and remove, so that we can create a space here, so that our next rota wire will go freely. So this removal with rapid spinning creates space and makes your rota wire exchange much easier. So, and that's what we did. And later, this is a 1.25 bar. So you can see we are doing ablation with 1.25 bar. So the entire length of CTO. And after that we did an IVUS. You can see here, so there's a good vessel, kind of 2 millimeter vessel distally, which is visible, and there is no calcium here, and you can see there is some calcium here, but around 90 degrees, and there is no place where calcium is beyond 240 or 270 degrees. So there is a good ablation of calcium, and the vessel size was actually increasing proximally. Distally it was like around 2, and you can see there is some calcium here, but there is a good break inside. Yeah, so, and the proximally vessel is almost 3 millimeters. We can see this is a LMCA, and there is some blocking in LMCA here, but overall lumen areas looks okay. And yeah, we decided to go ahead with a 2.25 28 millimeter stent distally, because there is a huge size mismatch from distal vessel to proximal reference, and proximally we stunted with a 3.3 by 33 millimeter stunt with the overlapping. So, and this is a final angiographic result of this case. So there's a good expansion of the stunt throughout with overlapping stunting. So I'll show the final IVUS result. So these are the lumen areas I have got. So proximally we have got almost 7.4 to 9 mm square. So ostial LAD is almost 7.4 mm square. So it's a good result. So So learnings from this case, balloon uncrossability accounts for 9% of CTO-PCI failures as per Progress CTO registry. Following methods can be employed based on feasibility in the case. Either parallel wire and using a seesaw technique with two 1 mm balloons, rota wire exchange followed by rotablation, or subintimal block crush, or retrograde technique. So, but in cases where there is poor distal vessel visibility, like this case, exchange to rota wire and ablation is a better technique to preserve distal lumen than parallel wire and seesaw or subintimal block crush, which reduces the visibility of your distal vessel. Rota wire facilitation can be done by removal of Gaia wire with rapid spinning. Yeah. So this is one flowchart which we can use in a balloon uncrossable lesions. You try to use smaller balloons, 1 mm balloon, or there is a nanocross balloon which is around 0.8 mm. And if nothing is crossing, you can do a grenadoplasty with an intentional rupture of the balloon by going to high pressures. If still not crossing, increase the support if support is an issue, and still not crossing, you can use a microcatheter to spin advance across the CTO, or you can also use Tornus catheter to cross across the CTO, and then you can use either laser or atherectomy. And if nothing is working, you can even use a subintimal techniques like external crush, or with a distal anchor, and you can also use combinations of these. So with this we can try to solve the case. Thank you, and you can subscribe to our YouTube channel, Interventional Strategies, or you can access all our videos through our website, drsharathreddy.com.